Well, thanks all for staying with us here on Sunrise Live on E. And of course, it is time for our health slot. Now, it is National Epilepsy Day. Now, epilepsy is a chronic disorder, which is the hallmark of which is recurrent, it's unprovoked, and it has the seizures. So many people with epilepsy have more than one type of seizure and may have other symptoms of neurological problems as well. So statistics have proven that approximately 65% of people newly diagnosed with epilepsy have no obvious cause, and that means that you've got no way of knowing it. Of the remaining 35%, the more common reasons include strokes, congenital abnormalities, brain tumours, trauma, and even infections. So to talk more about epilepsy this morning, we're joined by Dr Marlin Mckay. Dr Mckay, always a pleasure to have you.
Thank you, Faith.
Now, let's talk a little bit about this, because, I mean, when I was reading the intro there, that, 65%, they've got no sort of prior causes or the cause of epilepsy. So what do we say actually causes epilepsy?
So that's the problem. So what we say is, when someone presents with having had a seizure, and especially a repeated seizure, they are then diagnosed with an epileptic disorder or epilepsy, seizure disorder, right? Then the next step would be, what is the cause? And as your intro said there, at least up to almost 60%, 65%, we cannot find a cause. So it's called then idiopathic epilepsy. No obvious cause. And the problem with that is that it really can't be cured. And then you have the secondary causes where it is probably related to something else, and as a result of that something else, you get epilepsy, such as a head injury or stroke, a brain infection, stuff like that. So the difficulty for patients especially is just knowing that I have epilepsy. Doctors cannot find a cause, therefore I have to stay on medication for the rest of my life.
Now, how do you find out? I mean, it's not like flu where you get the sniffles and then your chest clogs up, and then, you know what I'm saying, like those kind of like signs and indicators that I may or may not have epilepsy.
Yeah, so absolutely. It's an unpredictable disorder. And so what happens, someone may just present, they may be as a child playing outside, or as an adult something happens, you collapse, and then something goes wrong in your body. It may start shaking. It may even present just with staring ahead or jerking of one part of the body. And then the classic one that everyone knows about is the collapsing and the shaking and the jerking of the whole body.
So literally, you fall and then you start jerking, or one of the body parts will jerk uncontrollably.
Yes. And sometimes there may not even be that loss of consciousness. Sometimes there's not even loss of just a fixed stare ahead, or a blinking of part of the body, or part of the one eye, for instance. So any of those, there's a wide range of presentations. So when there's something abnormal like that happens, ideally one should then visit your doctor, who can then refer you to a neurologist, who will then perform some tests, and usually to include a brain scan with an EEG. So an EEG where they place the electrodes on the head and they can measure the brain activity, and then usually come up with the diagnosis of epilepsy.
Well, we're talking epilepsy this morning, and if you've got questions regarding the conversation that we're having in studio, give us a call, 011-447-1742, alternatively 1620. So I'm going to try to cover some of the content here, but I also want us to take some of the questions on Facebook as well, because people have got some really relevant questions. I'm going to start off with Bongani. Bongani is saying that in my hospital file, and they went to hospital in 2006, they were diagnosed as an epileptic a patient. That was the first day I fell and woke up in hospital. After that, I went back in hospital in 2011 after I had stomach cramps. So they're afraid that could that be an indicator somehow that perhaps the epileptic seizures have come back? Yeah.
So I'd be very wary of labeling a patient like that as an epileptic patient with epilepsy. Usually the diagnosis must be made after several repeated seizures. So once off collapsing and landing up in hospital may not necessarily indicate. She may have had a seizure, the person may have had a seizure, but without necessarily being diagnosed with epilepsy.
So when does a person become diagnosed with epilepsy? Because I'm thinking, if a person collapses and they have a seizure, and they don't have a seizure for the next 2 years, 5 years, does that patient
that doesn't make it a disorder necessarily, and one cannot. It must be a repeated thing, and of course there must be evidence on investigation. The EEG must confirm it, and then of course the stomach cramps has nothing to do with it. So my advice here: get someone to question or to relook that initial diagnosis.
I've got another one from Christopher. Christopher saying that, is it true that epilepsy can be inherited? If not, what causes it? I mean, we've covered the causes that we don't really know, but the aspect of it being inherited?
So in certain cases, under this idiopathic thing where we don't really know, there may be a family history. So genetics may be involved, in the sense that if someone in your family has been diagnosed with epilepsy, there may be a higher risk or higher chance of someone else in the family.
I got you. Now, when we're looking at, having seizures themselves, now, so we're going to cover some myths now, having seizures. So a person is having a seizure. What do we do? Now, the common one that I would think that is a misconception, I don't even know if it's a myth or it's a fact, and you're going to clarify it for us this morning, the whole teaspoon or put their head back and make sure that the tongue doesn't fall off. What happens?
Okay, so this arises, someone woke up one day and decided, people, when they have epilepsy or seizure, swallow their tongue. That has never ever happened.
Oh,
so that's where
so that's not true.
That is
that
not
people are going to swallow their tongues.
They're not going to swallow. No one swallows their tongues. Impossible.
How? So I've been fooled for like all my life.
And you do more harm. The biggest danger with a seizure is the person getting injured in the process. So the seizure doesn't cause damage per se. It's the jerking and the injuring with objects around.
And so the falling part.
Yes.
Okay.
So number one, stay calm. Number two, stay with the person. Don't run away. Number three, remove any objects that may hurt the person in their jerking or in their falling. So chairs and cabinets and stuff. Just make the space nice and open, and allow the seizure to progress. Don't try and hold them down and stop them.
You have to allow the seizure to actually happen?
You can't stop it by keeping them still, by holding their head or holding their arms.
I've got more questions.
Injury.
I know I've got more questions now because of that, and which you've just busted. And we've also got your calls that we're taking this morning here on Sunrise. So I'm going to start with the Miriam. Miriam, you're calling in from Soweto. Good morning to you, Miriam. Okay, we seem to have lost Miriam there. Miriam tried to get a hold of us again, and let's see. Okay, so back to the questions like that. So you have to allow the seizure to actually take place. Does a patient ever start foaming at the mouth? And I think that's the part where people get scared.
Yes. So it's not really foaming, it's production of saliva. Because of the jerking, there's excess production of mucus, and they're not swallowing, so the saliva will come up. So everyone thinks foaming, close to death, do something drastic. Just stay calm. Obviously, hopefully someone, as you've called emergency services, so that someone can come and help. And you relax, and then you keep the patient on the side in the recovery position. So on the left-hand side, right?
On the left-hand side.
With the pillow under the head to support the head.
Got you.
Okay, and to make sure that the person is able to be comfortable and breathing. So here's a scenario of a secondary cause of seizures or epilepsy.
Trauma.
Trauma. Head injury. One has to usually associated with development of seizures and epilepsy, so they have to go onto medication. The seizures itself cannot cause brain damage. If you have a condition called status epilepticus, where you have a seizure for a long period of time, the person is unconscious for a long period of time, may cause some brain damage. But seizures per se won't lead to something like dementia.
Okay, so she's mentioning that this led
losing
to
the
dementia,
mind,
losing the mind.
I would suspect more the head injury rather than the epilepsy that led to the dementia. And of course, getting older, there's also a risk of developing dementia. We talk about senile dementia or Alzheimer's disease. So yes, the epilepsy may have played a small part, but I don't think it's the primary cause of the
So basically she needs to get another approach now in terms of
finding out.
Yes,
she needs to see a neurologist.
So then what happens with the medication aspect of it? And if a patient begins medicine, what kind of medicine do they start, and also for how long? How long does it start?
So once the neurologist or the clinic has made the diagnosis, this is a confirmed case of epilepsy, whether we know the cause or not, the person has to go on to what we call anti-epileptic drugs. So these are drugs that are specifically developed for the treatment and prevention of further seizures. So depending on the type of seizure which was classified, whether it's a partial or complex partial or the whole body generalized, the doctor will then decide on the appropriate treatment. And that person then has to take that treatment every day for the rest of their lives. Okay. Sometimes the doctor may, if they're seizure free for a few years, the doctor may consider withdrawing the medication and see if the patient can still carry on with the seizure.
If I'm on medication, this is one of them, is it curable? And this is a question from Lucy Williams saying that, is it curable? So you're mentioning that sometimes a doctor puts you on medication. If you do not demonstrate or do not have any seizures for a certain period of time, they may remove you off the medication.
Yeah. So generally, epilepsy being a chronic disorder and being a disorder without a known cause in those cases, by definition, one has to be on medication. As I said, and this must be with discussion with the doctor. The patient never makes that decision on their own.
Okay.
In a few isolated cases, the neurologist may decide, okay, you've been on the medication, you've been seizure-free for a number of years, and let's see if you withdraw or wean you off the medication and see what happens. Okay. But in general, the principle is, being a chronic disorder, it's lifelong treatment.
It seems like she's more disheartened in the fact that they're not touching, they're not doing anything.
Yeah. So if someone has epilepsy and they're on the medication, they should not have further seizures. If they are still getting seizures, then the doctors need to review the medication. What we first do is measure the amount of drug in the blood. and it has to be within that therapeutic range in order for the drug to work.
Gotcha.
They may then increase the dose or change the medication, but yes, I absolutely feel a pain. She needs further help in order to make sure that she doesn't get any more seizures.